Thank you, and good morning. Well, we had a really wonderful evening last night, beautiful setting, and I think now we're ready to get started. I'm just going to make some opening remarks to set the stage for today on the scientific agenda, with some thoughts about perspectives on acute unloading. So, what is unloading? And I think as we enter this field, I think it's important that we all start using similar language and kind of make consistent use of terminology. So we've put forward this definition, and we proposed this last year, and we're incorporating this into some of our early publications. We propose that unloading is defined as a reduction of the total mechanical power expenditure of the ventricle, which correlates with the reduction of myocardial oxygen consumption and hemodynamic forces that lead to ventricular remodeling. And really the goal of performing unloading is two parts. One is myocardial salvage, and Bill O'Neill's talk already alluded to this, that in the setting of an AMI, we want to minimize myocardial damage. The other very important thing is we want to prevent remodeling, because remodeling after an MI is the process whereby heart failure is generated. So these two things are, this myocardial salvage and prevention of remodeling, are related to each other, but they're not identical processes, and both of these are very important. The benefits of LV unloading are very well known and documented in basic and clinical research for decades. So this is a paper from 1985 from Pfeffer and Braunwald that actually they published on this prior to this date, but this is kind of the culmination. These are our studies that were performed in rat MIs, and these are the end diastolic pressure-volume relationships of ex vivo rat hearts. The gray shaded area shows the normal range, and what you can see is on the far right, these are the end diastolic pressure-volume relationships of rats without treatment, and what they treated these animals with captopril, a afterload reducer, and a preload reducer, and you see that the end diastolic pressure-volume relationship is curtailed. The degree of shift to the right is curtailed by captopril. It's not totally normal, but it's improved. And these studies led to clinical trials, the SAVES trial, the SOLVE trials, and others using captopril. And this translation from basic to clinical research really happened rather rapidly. And this is, you can see here the impact of captopril on end diastolic pressure, wedge pressure, and in the end diastolic volume. And you can see that the use of this afterload reducing and preload reducing agent reduced LV end diastolic pressure, reduced wedge pressure, and then prevented, not fully, but curtailed the degree of ventricular dilation. So this is what it's all about. However, there are inherent limitations to pharmacologic approaches. And we know that the more you unload the LV and decrease heart rate, these are the two factors that really contribute to the phenomena of remodeling and myocardial salvage, the more you compromise aortic pressure and cardiac output. So there are limits to what you can do pharmacologically because of these two factors. But appropriate device-based therapies can overcome these limitations. And in fact, as we've heard last year, and you'll hear more, combination of devices and drugs or non-device therapies that also reduce the workload on the heart, the power expenditure, can have synergistic effects. So this is really the essence of why we're here, is that we're going to be discussing the use of devices that can provide appropriate unloading of the ventricle. And here's a case in point, is the work from Bart Maines that we all know, which shows the infarct size in relation to the area at risk is quite large in a control animal. But as you increase the amount of unloading that you provide during the ischemic period and during reperfusion, you reduce the amount of infarct that actually occurs. And on the right side, the panel, it shows the relationship between oxygen consumption during the ischemic event or during the reperfusion period and the relationship and the percent of myocardial infarction. And this is really a key finding, in that this is telling us that unloading is not an all or none phenomenon, but there's a dose dependence of the phenomenon. So the more you can unload, the more you can reduce the oxygen consumption during the insult and during the reperfusion, the more myocardial salvage that you'll have. So there's a growing literature now to support the usefulness of unloading, and you all know these papers that are going to go by quickly, and many of the authors of these are here today and participated in the conference last year. And really, Naveen Kapoor's work has most recently brought this back to the forefront and has led to a lot of the clinical translational research that's now going on that we'll hear about today. And really, if we talk about what is the difference between drugs and devices, are really summarized on this slide. When you use a device, a left ventricular assist device that takes blood from the LV to the aorta, you can increase the perfusion to the body and maintain coronary perfusion pressure, while at the same time you unload the ventricle. And we have this phenomenon that we refer to as LV aortic pressure uncoupling. That means that the ventricular pressure and the aortic pressure don't have to be linked with each other. And this is really the essence of the difference between drugs and devices, and why a device approach to this problem will be much more beneficial in the end than drugs alone. In terms of oxygen consumption, I think we just want to recall that the determinants of myocardial oxygen consumption are not solely determined by the stroke work of the heart. And this is very important, especially when we start comparing different modes of mechanical circulatory support, specifically an LVAD that takes blood from the LV to the aorta, and compare it to, for example, ECMO, which takes blood from the right atrium and dumps it to the aorta. So the oxygen consumption of the heart is linearly related to the parameter that we refer to as pressure volume area, PVA, and it is the sum of not only the stroke work, but also this extra amount of energy called the potential energy. And there's a linear relationship between these two parameters, pressure volume area and VO2. And it doesn't matter what proportion of the total work is stroke work or potential energy, but it's really determined by the sum of these two. And of course, it's also important to note that when there's no external work on the heart is still consuming quite a lot of energy, and this is largely related to the energy for a little bit for basal metabolism, but largely for calcium cycling. And this is why, as we increase contractility with drugs, we increase the oxygen consumption independent of the increase in workload that the heart's doing because of the added energy required for extra calcium cycling. That in part explains, I think, some of the detrimental effects that we all know about in the use of pharmacologic agents to increase contractility to attempt to restore cardiac output and blood pressure in the setting of acute MI. So the other thing that we want to understand and keep in mind is the difference between acute unloading and reverse remodeling. And the point that I want to make with these slides is that this concept of unloading is not only limited to the benefits of unloading are not only restricted to acute MI, but also in the setting of chronic heart failure. And what we know from studies of chronic and durable left ventricular assist devices is that unloading has separate and important benefits to reverse remodel. So today we're going to be talking about preventing remodeling, but we also know that this concept of unloading is much more general and important in heart failure in that it can actually reverse remodel a heart. So if this is the end diastolic pressure volume relationship of a dilated ventricle that already has remodeled, you can apply a device to unload the heart, and you'll come down the same end diastolic pressure volume relationship. But what we know is if you sustain this unloading phenomenon, you will actually reverse remodel. So not only will you go down the end diastolic pressure volume relationship, but that end diastolic pressure volume relationship will gradually, over time, move back towards normal. And these are some end diastolic pressure volume relationships of human hearts that we measured at the time of transplant in patients that were not supported by a left ventricular assist device. The blue shows some normal hearts not amenable to transplant, and the red shows patients that were supported by left ventricular assist devices, and you see that these are back towards normal. Had they not been supported, they would have fell within this cluster that you see here on the right. So the benefits of unloading are broad in the cardiovascular system, and I think that we need to just understand the appropriate use of these in their different settings. So studies of left ventricular unloading are really in their infancy, if we really think about it. Basic research is accelerating. I showed you just a kind of an overview of some of the papers that are just now coming out. And clinical studies are really in their early stages. And I think one thing I want to emphasize is that I think now, at this stage, especially with the group of investigators here that are forming very nice collaborations, it's time to introduce consistency in the literature and into clinical studies. So I think that we really all need to start using similar terminologies and definitions. We need to really criticize and think critically about the methodologies that we're using. We'll hear about new methods and new results, and measurements of pressure volume loops in the clinic are very tricky. This is an area where we have to, I think, go back and be very cautious about what we're measuring and make sure that the conclusions we're drawing are based on sound methodology. I think in the clinical side, it's the time to establish clear definitions of the patient populations. We've seen already in the literature confusion within the cardiogenic shock, mechanical circulatory support literature, comparing papers that really are enrolling different patient populations. And I think we also need to think clearly about clinical trial endpoints so that we're all moving towards the same conclusions. With regard to terminology, I just wanted to make one point about the difference between the degree of support and the degree of unloading. And as I told you from the studies from Bart Maines, you can clearly see that the effects of unloading are dose dependent. And sometimes these terminologies are getting mixed up in the literature. So this shows pressure volume loops in the faint orange you see here, normal, and then we have here a loop which is supported by a left ventricular assist device. And you can see at the bottom here, the aortic pressure and ventricular pressure are still coupled. And so this, we know, in this kind of setting, we know that the heart is ejecting because you have here the ventricular pressure is just exceeding the aortic pressure. So this is a situation where we have partial support. That means that the heart is providing some of the output and the ventricular assist device is providing some of the output. And we have, compared to the baseline, we do have a decrease in the myocardial oxygen consumption as indexed by a small reduction in the pressure volume area. If we increase now the degree of support, what you can see here now is that the ventricular pressure does not reach what's in the aorta. The pressure volume loop is slightly shifted further leftwards. So we're providing more support here, and in fact we're providing full support in the sense that the entire cardiac output is now being provided by the assist device, and the heart is not ejecting. So that we refer to as full support. But the heart still has some load on it, so it's still partial unloading. It's more unloaded than we started here, but it is still partially loaded, is still largely loaded. But we've decreased the myocardial oxygen consumption further. Whoops, 2 minutes. So in this panel now, we've now increased the degree of flow from the device. We have further uncoupling between the LV and the aorta. So this is still full support, but it's still partial unloading because there's still a load on the ventricle. So we've decreased the myocardial oxygen consumption further, but we're still in a situation with full support and partial unloading. It's really not until you fully unload the ventricle and have zero work that you would consider this to be both full support and full unloading, and this is really the point where you would have minimum myocardial oxygen consumption, where the PVA is nearly obliterated. So this is just one example, because in some papers we kind of interchange the word full support and full unloading, but there is clearly a difference between support and unloading. And again, this emphasizes the point that that unloading is dose dependent, and when we translate this into the clinical practice, I think that we have to understand that if we put a device at a certain flow rate, it may not mean the same between patient 1 and patient 2, depending on their particular loading conditions that result from the use of the device. So that's an overview of what I wanted to introduce. We are, one of our efforts that is related, a parallel course to ACURE is this TEACH initiative that we have started, which is a training and education in advanced cardiovascular hemodynamics, where we're trying to, in parallel with ACURE, to enhance and disseminate the understanding of basic hemodynamic principles. We're doing our second courses this year at TCT. We'll have Teach 1, which is the basic course, and then we're going to Teach 2, which is for people who've taken Teach 1. We're going to continue the degree of education to offer more in-depth training in this field. So today we have a very packed agenda. As Naveen said, we were asking for the speakers to basically stay on time. We saw that some of the speakers had 40 or 30 or 40 slides. You may want to consider, if you're in that group, to go back and maybe hide some slides, because the slides will stop after 12 minutes. So this is the agenda. You have the agenda in front of you. And with that, I will close, and I'll be happy to answer any questions. Thank you very much.
Thanks for a really nice overview. So while people think about making their way to the microphones, maybe I'll get us started. Why do we have such a hard time with the concept of recognizing that this is a time-sensitive intervention?
Yeah, that's very, very important. And the preclinical studies that we've referenced already, several of them, really show that time is a very important thing, because time, this actually gets back to the adage that time is muscle. So once in the setting of an MI, if you, the longer that you allow the heart to be loaded, the myocardial necrosis is going to proceed very quickly. So we have very limited time to salvage the myocardium. So while the emphasis has traditionally been on opening the artery, as we'll hear in later talks today, now we're testing the hypothesis that actually unloading the myocardium, reducing the myocardial oxygen consumption as quickly as possible is going to be as effective and contribute equally to the salvage of myocardium. So time is a very important thing because of the degree because necrosis occurs as soon as you limit the myocardial perfusion.
Dan, thanks for this overview. One of the things in your slides is that you keep using the same EDPVR. Do you think unloading will have an effect on the slope of the EDPVR?
I think that the EDPVR, unlike the ESPVR, which changes very rapidly in ischemia, the end diastolic pressure volume relationship is determined more by structural things like the extracellular matrix and the organization of the myocytes. So changes of the EDPVR take time. You saw even in the rat studies, there's a time dependence. In some of the other papers, even that they published in the late 70s, early 80s, showed, if you look at this at 1 day, you only have a little bit, after an infarct, you have a little bit of a change. If you look at it at 7 days, you have more of a shift to the right. So we know from basic science and also clinically, a patient will present with a small heart and heart failure acutely. This is because the EDPVR really is determined by, I think, more structural factors and the size of the myocytes and their organization, which is determined by the extracellular matrix. So it takes much more time for the EDPVR to shift. So we have a little bit more time to intervene on that side, but once myocardium is dead, the remodeling process starts. We also know from the durable VAD that it takes time for the heart to get small again. So that EDPVR will take around 3 to 4 months to go from this very dilated state to where it will ultimately wind up.
Dr. Tedford?
Great talk as usual. So it's pretty easy at the bedside to tell when you have full support, when the aortic valve's not opening. But when you don't have the benefit of seeing the pressure volume loops in real time, how do you determine the degree of unloading that's actually taking place? Do you just keep going? Is it ventricular size? What kind of parameters are you looking for?
Well, I think, first of all, in terms of the degree of support, whether it's full or not, you can look at the pulse pressure. So if the pulse pressure, as the device takes over for the heart, the pulse pressure will decrease, and sometimes you can even have a flat line. So if you see that, don't worry, that's actually what's supposed to happen. But with regard to the unloading part, I think really the best way clinically, since we're not going to have pressure volume loops, is to look at the wedge pressure. And if you happen to have the benefits of having a right heart cath, which many of us think, these patients really, if you're sick enough to require a ventricular assist device, you probably should have a right heart cath so that you can optimize the therapy. So that would be the best way. Now you're going to be limited in a clinical situation. You can't fully unload the heart because you are going to run into suction, arrhythmias, et cetera, all the practical limitations. But I think using the wedge pressure is probably the best way in the clinic without the benefits of a pressure volume catheter to assess that.
Thank you very much, Dr. Burkhoff.